It is well established that change in ventilator flow in tidal volume and inspiratory time rapidly influence the frequency, inspiratory and expiratory time of a subsequent breath. Purdy and Younes originally found that an increase in ventilator inspiratory flow from 30 to 90 liters per minute induced an increase in respiratory rate from 9 to 13. This float-associated tachypnea is, according to Fernandez, related to the decrease in the neural inspiratory time, as shown in this slide, and as well as shown in this graph, plotting the flow against neural inspiratory time. But the flow-associated tachypnea is not related to a change in the neural expiratory time. Flow-associated tachypnea is believed to be mediated by vagal stretch receptor as it persists after anesthesia of the upper airways and denervation of receptor in the lung and chest wall. It has been also reported that increasing the inspiratory flow rate induces an excitatory effect on respiratory output. Conversely, an increase in the tidal volume induces a decrease in the respiratory rate, mostly by decreasing the neural expiratory time. So, as the flow is derived from the tidal volume and inspiratory times, the respective effect of change in ventilator flow, ventilator tidal volume, and ventilator inspiratory times have been assessed by Legge. And as shown in this table, when the flow and tidal volume were both increased, there was no change in ventilator inspiratory time and no change in the respiratory rate. When the ventilator flow was increased and the tidal volume was kept constant, there was a decrease in ventilator inspiratory time and a subsequent increase in the respiratory rate. When the flow was kept constant and the tidal volume was increased, there was an increase of the ventilator inspiratory time and a decrease in the respiratory rate. And interestingly, when the flow and the tidal volume were both kept constant, there was, and the ventilator inspiratory time was increased by aiding inspiratory pause, there was a subsequent decrease in the respiratory rate. Altogether, this result suggests that respiratory rate is mostly depends on the ventilator inspiratory time. So I'm quoting Tobin, who said that the response of frequency to a change in ventilator setting is complex because it depends on the relative dominance of physiological mechanisms acting in different directions. Numerous studies have reported that mechanical ventilation reduces the respiratory center's output through mechanical feedback. As you can see, I'm sorry this slide is out of focus, but as you can see, during pressure support, there was a decrease in the diaphragm electromyographic activity in comparison to spontaneous breathing, even when normocapnia was restored. This reduction in the respiratory center output is quite rapid phenomenon, taking about 10 breaths to reach a new level. Neuromechanical inhibition has been demonstrated in awake and sleeping healthy subjects at various levels of CO2, ranging from hypocapnia to hypercapnia, by using various indices of respiratory motor output, PO1, PTPDI, and EMGDI, with various modes of mechanical ventilation, including control and assisted mechanical ventilation, but also pressure support ventilation. Its preservation in double lung transplant recipients remains controversial. Interestingly, it seems that the neuromechanical feedback may play a role in the occurrence of apnea after discontinuation of control mechanical ventilation. In Doug, Sato reported that the length of post-control mechanical ventilation apnea depends on the duration of control mechanical ventilation, but as well as on the level of tidal volume delivered. However, the existence of a reduction of neuromechanical inhibitory feedback on the respiratory output remains highly controversial. I'm quoting the argument listed by Magdi Younes in the Blue Journal. As you know, there are different chemoreceptors, some sensitive to the PCO2 oscillation or to the PCO2 levels. And we can argue that the reduction of respiratory center's output during mechanical ventilation is related to a chemical factor that has not been detected. And because, for instance, of the inadequacy of end-tidal CO2 to detect PCO2 oscillation. There is a controversy about which indices to use in order to measure the respiratory center's output. And one may argue that the PT-PDI or EMG-DI are inaccurate during mechanical ventilation because of the contractile properties of the diaphragm or because of the displacement of the esophageal and surface electrodes during mechanical ventilation. Moreover, some studies have not found a reduction of respiratory center's output during mechanical ventilation, either in healthy subject, or in patient with acute lung injury. Condili reported that mechanical ventilation influences the respiratory timing, but not the respiratory center's output in patient with acute lung injury. So we move to the second part of my presentation. The effect of mechanical ventilation on the cortical drive is by far unknown. There are two methods to assess the cortical drive: functional brain imaging and transcranial magnetic stimulation. It has been recently reported that during a passive voluntary inspiration, there are fewer, there are fewer cortical regions activated during a voluntary inspiration than during a passive inspiration, including the temporal lobe or the parietal areas or the supplementary motor areas. By using a specific coil which generates a magnetic field, transcranial magnetic stimulation elicits a contraction, a contractile and an electrical response of in the targeted muscles. The amplitude of a motor evoked potential is increased during a peripheral pronunciation or a central facilitation. Its amplitude is decreased during, in case of depression, as observed after exercise. The amplitude of a motor evoked potential depends also on the intensity of a stimulator output. In this slide, you can see the relationship between the intensity of stimulator output and the amplitude of a motor evoked potential amplitude. This recruitment curve is characterized by the threshold, by its slope, and by the value of a motor evoked potential for a maximal intensity. We have assays in the effect of non-invasive normocapnic mechanical ventilation on the recruitment curve of the costal and crural diaphragm in 6 healthy subjects. There was no difference between spontaneous breathing before mechanical ventilation and after mechanical ventilation. The respiratory rate was kept constant throughout the study, and there was a significant decrease in the PT-PDI and EMG-DI during mechanical ventilation without significant change in comfort of breathing. But most of all, we found a dramatic decrease of the motor evoked potential amplitude of the costal and crural diaphragm during mechanical ventilation. And we didn't find a decrease of the response to peripheral magnetic stimulation, implying that it's not a peripheral phenomenon. Interestingly, here are the recruitment curve during spontaneous breathing before mechanical ventilation, during mechanical ventilation, and then after mechanical ventilation. And as you can see, there is a shift downward of the recruitment curve with an overall decrease of the motor evoked potential amplitude, a slight increase in the slope, in the threshold, and no significant change in the slope. We found the same result for the crural diaphragm. So there is a depression of the motor evoked potential of the diaphragm during mechanical ventilation. That this depression can take place at spinal, bulbar, or cortical level. In order to, so we further assays, we further investigated the a cortical phenomenon by using pair stimulus, which assays the intracortical inhibitory circuits and the intracortical facilitatory circuits that modulate the motor cortex excitability. Paired transcranial magnetic stimulation consists in two stimuli, a conditioning stimulus and then a test stimulus. And for a short interstimulus interval, the intracortical inhibitory circuits are activated, decreasing the motor cortex excitability and then the amplitude of the motor evoked potential. And for long interstimulus interval beyond 7 milliseconds, you see the opposite effect. So here are the response to transcranial magnetic stimulation during spontaneous breathing, then during mechanical ventilation, and during spontaneous breathing after mechanical ventilation. And as you can see, for a facilitatory interstimulus interval, the motor evoked potential amplitude of the costal diaphragm is higher during mechanical ventilation than during spontaneous breathing. And there is also a carryover effect of mechanical ventilation and the subsequent response to transcranial magnetic, paired transcranial magnetic stimulation. So these findings suggest that mechanical ventilation induces an increase in the excitability of the facilitatory intracortical neurons. Interestingly, we have studied 7 COPD patients, and we have found that the race for facilitatory interval, interstimulus interval, the motor evoked potential amplitude of the costal diaphragm is smaller in COPD patients than in HMH control, and the CO2 level, PCO2 level were equivalent in the two groups. This suggests that there is that the excitability is lower. The excitability of the facilitatory intracortical circuits or neurons is lower in COPD patients. So because mechanical ventilation is maybe required at end-stage COPD, it will be worthwhile to assess whether mechanical ventilation restore the excitability of the facilitatory intracortical neurons. So this is my conclusion. In conclusion, we found that a depression of the diaphragm motor evoked potential amplitude during non-invasive normocapnic mechanical ventilation. We think that it's as this depression is related to a neuromechanical inhibition at spinal, bulbar, but also cortical level. It is associated with an increase in excitability of the facilitatory intracortical neurons. The relevance of this phenomenon to patient-ventilator interaction needs to be addressed. I would like to thank my colleagues, Dr. Euren Ross and Dr. Nick Hopkinson, for their great help, and for their advice, Professor Frédéric Lofazo from Garges, Professor Thomas Similovsky from La Pitié-Salpêtrière in Paris, and Professor John Moxham from King's Hospital in London, and Dr. Michael Polke from the Royal Brompton Hospital in London. Thank you for your attention. Sorry.